Well, hello everyone. Thanks for joining. Super excited for this new format. I didn't get to go to all the VMRs this week. I tried to, but I didn't get to go to. So I'm especially excited to recap the cases from this past week. And because there's no session that is as time crunched as this one, we're doing a lot, 6 whole cases in an hour. We're actually going to jump right in and hear about Sunday's case from the one and only Shema.
Hello, everyone. So I will try to keep it short. During Sunday's case, that was presented by Anne-Marie. We had a 22-year-old male presenting with fever, chills, esophagitis, and the chief complaint was odynophagia. And it came out it was an HSV esophagitis in an immune-competent host. And the teaching pearl that I made myself was for the chief complaint of odynophagia, that so basically pain while swallowing, that this can be an inflammatory issue, so an infection, an itis, or a mechanical issue. That's my first teaching pearl. And the second pearl that I have is basically the most common bugs causing infectious esophagitis are CMV, HSV, and Candida. And before saying something about the endoscopy, I made myself a mnemonic. I read that HSV can cause esophagitis in immunocompetent hosts. Suspect Candida when the CD4 count is below 200, and suspect CMV when the CD4 count is below 50. And the last thing that I mentioned is basically what Mukund says. He saved the VMR by telling us what to expect in the endoscopy, like for HSV, well-circumscribed volcanic-like ulcerations; for Candida, mucous plaque-like pseudomembranous, and for CMV, more linear and deeper longitudinal ulcerations. Yeah, that's all.
Shema, that was incredible. What a concise recap and full of pearls. Just to reflect with you, how do you feel like your mind is conceptualizing odynophagia versus dysphagia? Like, what does that do for your mind, those two things?
I have to say, I was very overwhelmed when I was doing the discussion because I actually never had kind of a schema how to approach odynophagia and dysphagia together. But later, for me, it's just that one is causing pain and the other is not causing pain. So this was basically my approach.
Beautiful. I think that's exactly right. Dysphagia and odynophagia are probably best mapped onto concepts that we're more familiar with. And the concept that I think is analogous to this is bowel obstruction. So patients with small bowel obstruction or large bowel obstruction have nausea, vomiting, and don't have much pain. They really shouldn't have much pain. And if those patients have pain, they usually have had bowel infarction, so ischemia as a result of this. In large contrast to patients with colitis, inflammation of the small bowel or large bowel who have a lot of pain. So odynophagia is essentially esophagitis, inflammatory diseases of the esophagus, and dysphagia is just an obstruction, really an obstruction so high up it's in the esophagus. So you can take small bowel obstruction, large bowel obstruction, and apply the same principle and call it dysphagia. It's the same issue. There's something in the way, or there's a motility issue. And odynophagia is esophagitis or inflammation of the esophagus. So I think that's a helpful place to start. And I love the pearls about the infections that are at play here. Do you have a sense, Shema, of non-infectious causes of esophagitis that come up in your reading?
Mm-hmm. So eosinophil esophagitis, also radiotherapy induced, or generally also zoledronic acid. I remember this was one pearl that I was once asked in the clinic, like, what do you have to be cautious of if you give someone zoledronic acid? Always keep them in the upright position because it causes something like, I forgot English, sorry.
No, you didn't. You nailed it. You nailed it. You were telling us a lot of medications do this, and you told us also the importance of pH. So patients with a very low pH can reflux and cause esophagitis, and also told us about autoimmune diseases like eosinophilic esophagitis. Just yesterday, I saw a case of esophagitis, and it reminded me of the two P's. So if you're trying to incorporate odynophagia equals esophagitis in a systematic manner, you will not think about anything until you've assessed for the two P's: pills, so medications, and pH. So always odynophagia equals first the two P's, pills and pH. And the pills that are commonly implicated are antibiotics like doxycycline, bisphosphonates. NSAIDs are also implicated in this, as is the anticoagulant dabigatran. You can also get it from potassium chloride. So there's a long, long list. And pH simply refers to acid. So acid reflux can irritate the esophagus. Cool. Thank you for that recap. That was super, super interesting case. I'm curious just to open it up to anybody to see if anybody has any questions before we move on to Monday's case from Madellena. Cool. All right, let's move on.
Okay, awesome, Shema. That was such a beautiful summary. So thank you for doing that so concisely. So I get to present Monday's case. So Monday's case was really quite the journey of a case presented by Gurleen, and the discussants were Drs. Jill Harrington and Soda Ahmed. So I will try to give just kind of a two-sentence summary of this case. So this was the case of a 65-year-old man who had a past medical history of cirrhosis in the setting of alcohol use, and also this kind of chronic low back pain, who was now presenting with this several-month kind of subacute history of frequent falls, kind of an acute on chronic low back pain, ultramental status, and then this hyponatremia to 121. And there was quite the extensive workup, but the most notable things I'll highlight was this neutrophil glucocytosis, severely elevated CRP to 103, and then ultimately an MRI of the spine that revealed an epidural abscess and osteomyelitis growing Enterococcus fecalis. So really, I was trying to reflect on what were the main points to highlight here. And to me, really the main learning point was actually about the power of framing the problem with the problem representation. And by continuously updating the problem representation and kind of changing the way we're framing the case, that allows us to keep track of what the center of gravity is and where we should be putting our cognitive energy. So just kind of to walk through examples of how that happens. So initially, Gurleen gave us kind of like the chief concern of hyponatremia that was present on the current and on the past admission. So we started discussing how to approach hyponatremia, and we can kind of get to that in another learning point. But then after hyponatremia, we got more information about, oh, okay, there's back pain, there's a history of more frequent falls and ultramental status. That kind of changed where our focus was in terms of kind of a schema for ultramental status, and to what extent should we include back pain in our problem representation. And then as we got more information, that turned into a framing of cirrhosis decompensation. So kind of ultimately the summary is that kind of when you get a bunch of data that doesn't exactly fit in, just kind of go back to the history and reframe the case so that you can be very intentional about where you're putting your cognitive energy. And we actually asked Jill and Soda during the discussion about what helped them determine the center of gravity of the case, but I actually wanted to open it up to the group to see, kind of like brainstorm together, like when you're given so many different problems and you don't know whether you should be focusing on hyponatremia or back pain or ultramental status or all these things, like what strategies can we use to figure out what the center of gravity is and where we should be focusing our energy. I wanted to poll the group and see what you guys think.
I would go with the problem with have less differential diagnosis.
Yeah, exactly. So what you're saying is like choosing kind of the problem that has a narrower differential. Yeah, I agree. And then Hans also said maybe focus on the most life-threatening causes. I think that's also a really important point. What's the most morbid of the causes to focus on?
I want to add on, maybe give my 2 cents on the matter. I think considering the inpatient setting more specifically, at least what we try to do in the hospitals that I've been in, is to try to approach the problem, the situation that is easier to resolve. So for example, hyponatremia could be causing the altered mental status. And with that, maybe if you fix one, then you get away with resolving two problems at once. So I think the ones that are most immediate in terms of this could be treated first, and then we can see the rest, could also be an alternative. I think more specifically in places in which you don't have many resources, that could be a solution. Like, we want to give the best to the patient, but sometimes you're just stuck and you can't exactly do what you want to do. So I think that could also be an approach.
Yeah, Daniela, thank you for mentioning that. I think that's such a unique and important point that you mentioned, because it's very practical. It's like, what tools do you have in front of you to address one of the many problems that the patient has? And you also touched on a point that I think I heard on a recent CPS episode. I remember Simone was sharing it, and it was a different case, but the takeaway was that the patient had diarrhea and a few other problems. And the example was that, I think the diarrhea was caused by opioid withdrawal. So if you address the opioid withdrawal, that may take away some of the other problems you're trying to keep track of. So it's a really important point. Some of just sharing what Jill and Soda shared when I kind of asked them this question, they mentioned also, I think what Hans shared, like, what is keeping the patient in the hospital? So what are the most morbid, life-threatening concerns we need to think about? And then also what the patient's chief concern is, because maybe the patient's chief concern is not the most life-threatening, but that's likely what's most important to the patient. So you really want to make sure you address that. So that was kind of one of the main warning points that I took away. The second one is hyponatremia, just because it can so often be a intimidating topic to address. So let's see. Well, I guess before I dive into that, I wanted to make sure I gave time to anyone in the chat to have time to kind of ask questions about this case before we dive into my thoughts on the hyponatremia. But kind of open, just wanted to leave it open. Anyone have any questions about this case? So Hans, you're mentioning, it sounds like you put it in the chat, your question about like what was the cause of hyponatremia in this case. Oh, let's see, on there. Also go back to the patient and ask again. Okay, so Hans, I might just kind of emphasize the question that you mentioned. So as we talked about, hyponatremia was a really key part of this case, at least that we spent a lot of time focusing on. And the discussants talked about the importance of looking at the chronicity, and then also some important labs, the urine and serum osms and the urine sodium. And there was also an interesting discussion of how much weight to put on the volume status, because it can be very difficult just from your physical exam to distinguish between hypovolemic, euvolemic, things like that. So that's why we are focusing more on the exam and labs. But I actually also personally had a question about what the underlying cause of hyponatremia was in this case. And kind of I can go through my thinking, but I also wanted to pass the mic to Robbie, because I feel like you probably have a lot of pearls about where to put our focus on in terms of working up hyponatremia, to what extent we should, how much weight we should put on the physical exam and the volume status versus whether that's not helpful at all. So I wanted to hear your thoughts on that.
Yeah, I think that you're tasked with summarizing and describing probably the most complicated case this week, and maybe the most complicated case we've had for a while. And I think that the hyponatremia, and in most cases, is simply just a barometer of how bad things are, be it from hypovolemia or from SIADH or from the severe alcohol use disorder. So it very rarely kind of leads you to the diagnosis. It more is the diagnosis is otherwise just more severe based on the hyponatremia. And I think that the hard part about hyponatremia is I think we try too hard. up front. So often when you're attending may come to you and be like, oh, the patient's sodium is this, what's the answer? And you're like, wait, hold on. It's no different than the EKG, right? Like you look at the EKG and all you really want to say is, hey, there are no ischemic changes, it looks fine. But all of a sudden you find yourself looking at the QTC and the PR and whatnot. Take it a step at a time. So the first thing you want to do with hyponatremia is to classify it into one of two mechanisms. Is it ADH mediated or is it not ADH mediated? That's the first step. And so the way you answer that question is you recognize the unique property of ADH. And the unique property of ADH is to concentrate the urine. No other molecule is able to concentrate the urine. So if your urine concentration or osmolarity is higher than your serum concentration or osmolarity, you know that ADH is on board, right? That's as simple as that. And so in most cases in patients who are hyponatremic, by definition, their serum osmolarity is less than 300. So if your urine osmolarity is greater than 300, you know ADH is on board. Now it gets a little bit tricky in the intermediate zone, but let me paint the other extreme. If your urine osm is less than 100, that is the most dilute urine your kidney can excrete. And so if your urine osms are less than 100, you know ADH is not on board. So if you happen to be lucky that your patient's urine osm is either greater than 300 or less than 100, you know that in the greater than 300 situation, ADH is on board. And less than 100, there's no ADH, period. If there's no ADH on board, there's not much left that causes hyponatremia. It's one of three things. Your patient's drinking too much water, eating too little osms or too little salt, or has CKD. That's simple. So if your urine osm is less than 100, you talk to your patient about their diet, how much water and how much food they take, and look at their kidney function. If it's more than 300 and you know ADH is on board, you have to figure out, is ADH doing its job appropriately or inappropriately? And that's when you have to look at the urine sodium. Why the urine sodium? It has nothing to do with hyponatremia. What you're trying to do is to figure out, is the renin-aldosterone system on? Is it working? The RAS system. And ADH is appropriate only if it's working with its other buddy, the other A, aldosterone. If aldosterone is off and ADH is on, that's inappropriate. If aldosterone is on and ADH is on, that's appropriate. So aldosterone determines the appropriateness of ADH. Now you could get really fancy and measure a serum aldosterone level, but that takes forever to come back. So you use a proxy. And the proxy is that aldosterone sucks back sodium into the body. That's what it does. So if the urine sodium is low, you know aldosterone is on and you know that ADH is working. If the urine sodium is high, aldosterone is off and ADH is not, and aldosterone is not working, so that's inappropriate. So that's what you should try to do in the beginning. And in most circumstances, you'll be able to get to the answer. And the caveats will be, what if my urine osm is between 100 and 300? That makes it a little bit tricky. And what if I've given something that artificially elevates my urine sodium, such as a diuretic? Those are the two caveats to this analysis, but we won't go into the caveats. In most times, you'll be able to find the answer by looking at the urine osms. If it's less than 100, it's not ADH. Water, salt, kidney. If it's greater than 300, it's ADH, and the key question is aldosterone working or not? And all you have to remember about aldosterone is it sucks back sodium into the body, lowering urine sodium. So do you happen to remember the numbers from the case on Monday?
Yes, I do.
Yeah, let's
okay, so the serum osms were 253.
Perfect.
So we could put that in the bucket of like the hypoosmolar hyponatremia. Yep. So then we have the urine osms, which were 252.
Okay, all right.
So that was high. That
okay.
means ADH is active, right?
So technically that's in the intermediate zone of between 100 and 300, right?
Right.
Yeah. So yeah, but what was the urine sodium?
Okay, so the urine sodium was less than 20.
Okay. All right. So let me tell you this. When your urine osm is only 252, that means your hyponatremia is not that bad. So I wouldn't spend a lot of time trying to figure out this hyponatremia simply because the urine osms are so low. And that tells me that the urine is relatively dilute, which tells me that this person is getting rid of all the water they have on board. this person's not going to get into trouble from hyponatremia. So I don't spend too much time when the urine osms are this low. And the reason is because the mechanisms are multifactorial. It's no different than spending a lot of time with a hemoglobin of 9 in a patient who has CKD and glomerulonephritis and HIV and takes an immunosuppressant. Like they have multifactorial mechanisms. So this patient's hyponatremia is likely multifactorial, driven by the cirrhosis. But guess what happens when patients with cirrhosis get enterococcal bacteremia? They don't eat well. So I would say that this person probably has a combination of ADH mediated, but mild ADH, and tea and toast hyponatremia. But if the urine osmols are that low, it tells you that the stimulus of hyponatremia is very mild and that there's so much water in the urine that this person will clear out all the excess water they have. So don't spend too much time on a urine sodium that's not more than 300. Not worth your time. Does that make sense?
Awesome. Yeah, it does. No, thank you. That was a helpful approach.
I forgot that we're recording this, so all the nephrologists who are listening to this are going to come after me. But it's true. I don't spend time on a patient whose platelets are 130. I don't. Like the yield on investment for that is very little. The sodium police, yes, Shema. Yeah, and I think that the point that you were articulating earlier about how the problem continues to evolve and how you can be distracted is the most fundamental point in clinical reasoning. It doesn't get much more complex and much harder than that. And it simply reflects the truth that if you don't know what problem you're solving, no matter how strong your reasoning is, you're going to find the solution to the wrong problem. So I think the exercise that you just walked us through collectively is a lifelong journey that all of us will be on and will never get right. And I could share a story with you about yesterday, how I got it wrong, but that will take us far, far too long. So I'll save it for next time. Thank you for that. That was a tricky case to recap. I thought you did it really, really well. Questions from the group? All right, Deborah, you're up.
Okay, so going for the case of Tuesday is the focal case that we are having, and it was a 44-year-old male with dyspnea, cough, and fever. He presents like cough and like dyspnea and exertion. So besides the cough and the fever, so they think about it, heart failure, or maybe it could be a TB. And the patient, it was from Peru, but like moved to US a few years ago and had like just diabetes and didn't take, everything else was like irrelevant. And the patient was presenting with fever, tachycardia, tachypneic, and in the left lung, they presented with decreased breath sounds and rales and dozenness percussion. And then we had like Dr. Ria that did an excellent job about doing the pulse imaging. I can't have produced her everything that she said, but we saw that had some fluid in the pleural and the pericardium. And one of the things that she said that really brings my attention, it's when she asked to see the IVC and has to be like 2 centimeters. And when we inspirate, the IVC has to collapse more than 50%. And in the patient that we were seeing was not happening that. So she said that's indicated that it's a high right atrial pressure. So, and then they did like, they called the cardiology and did a pericardiocentesis and then got some bloating. And then in the pleural fluid, get some exudative and high LDH. And then both was red bloating. And another thing, it was what that I learned like a pearl, that Ravi said that the high LDH can be associated with PJP pneumonia. I didn't know that. Besides like hemolytic reaction, organic dysfunctions, vasculitis, lymphoma, leukemia, all that. And I took some notes, that's what I'm reading. And They have a question. I just watched the video. I was not connected. I was on vacation, so I can ask for the group. If the bloater infusion can be caused by a fungal, Dr. Ria asked that, and I don't know if anyone has any knowledge about it.
I have no idea. Yeah.
Okay, we can look for it to study. So yeah, and then this patient, they thought like that could be TB. Exactly, he was from Peru, and start treating the patient, and the patient didn't improve. Actually, the patient got worse, got intubated, has to be pressed for hemodialysis, and then they keep testing the patient for TB, even with the treatment didn't get better. And in the end, they got the diagnosis of non-small cell lung cancer. So things like that I took from the case, they said like, even this patient, you have to keep testing the patient, even that you don't get the diagnosis, because you have more chance about that. That's what they did. They keep testing the patient because they didn't know what was happening. And the patient died. It was a sad case. He was super young. And for all the blood infusions, they think about can be TB, malignancy, or autoimmune as the most differential diagnosis. So yeah, that's my reflection.
Yes, that was such a great reflection, and I think you know, Deborah, the hard part in many people who are coming in with dyspnea and cough is to figure out they have a pleural effusion, and POCUS has revolutionized that. You know, before you would do an exam and you would hear reduced breath sounds and dullness to percussion, but those aren't that good. You literally can just put and see and visualize the effusion, and you know, all of us learn effusion, is it exudative or transudative? But on ultrasound, you can see if there is inflammation with fibrin deposition and loculation. So you don't even need Light's criteria sometimes to determine that something is exudative. The ultrasound has revolutionized that. And this case also reminds you that the IVC can be big from a pleural effusion. Now you may wonder, wait, why does that happen? I'll emphasize that you know this already, because you know a pericardial effusion can cause an IVC to be big. And what a pericardial effusion is doing is just increasing the pressure on the heart, right? And that pressure goes back into the IVC. A big pleural effusion can also compress the heart, and it's just harder for it to do it. So the model that you should have is not, there's nothing special about pericardial effusion. It's all about the pressure on the heart from outside, intrathoracic pressure. So when you have pneumothorax, that pressure is on the heart, and that causes tension pneumothorax. When you have big hyperinflation from asthma, you can get hypotensive because of that reason. So this case was a really nice reminder that ultrasound is very helpful to look for an effusion, and also that effusions can have compressive hemodynamic effects. Very nice demonstration of the value of ultrasound. I'm still learning how to use ultrasound, but its ability to tell you what's going on is incredible. Thank you for that summary. That was really, really cool. Any questions from the group? All right, Promise, take us away.
Okay, so for Wednesday's case, we have a 38-year-old male with a history of psoriatic arthritis, and he's taking secukinumab, which is an immunosuppressive drug. Recently traveled to Panama, and he presented with right foot lesion, a rash, fever, arthralgias 3 days after he returned. And notably, there's redness in his foot that spread upwards, and his rash was diffused over his upper and lower extremities. And I think kind of reflecting on the case, looking retrospectively, I think that this case has a lot of information. It was presented by Garlene, and it was discussed by Jack and Charmin. And so there was a lot of information going on. Nothing really fit like a certain script. The only progress we really made was we kind of, when we think about fever, we're thinking inflammation or like infection. But because of this patient's recent travel and all these symptoms, we were just thinking, like we narrowed down to thinking this is probably more of an infectious cause. But after that, we were kind of stuck because the vitals, exams, labs, imaging, and then we sent in a bunch of testing for different kinds of infectious causes like parasites, like all of that came back negative or normal and nothing really too specific. And so we were really stuck. And if I have to look back and think about what was the pivot point of this case that really helped us make progress and treat accordingly to improve the patient's symptoms, was that Garlene and her team went back to retake the history. And that's how they found out that the patient told them like botfly larvae is like, is like endemic in the area. A lot of people have it. And when people take out the larvae, they feel better. And that's really how they figured out, because nothing really fits the script, everything kind of came back negative, CT imaging, like all of that was, didn't really give them anything. So that may be the most likely cause of this patient's symptoms. And when they went in and took out that larvae on his foot, the patient instantly, he got better. And so I think my key takeaway of this case would be, I think, well, for one, like myiasis should be considered in patients who develop like a lesion after traveling to endemic areas. And it's really important to take a detailed history and also just kind of even just ask the patient, do you know what are some like common like endemic infections in that area, if they know it, instead of just really anchoring too early and then maybe misdiagnosing with like, a cellulitis by staph or something like that. And just treat with antibiotics, which would get you to a completely different route and the patient wouldn't really improve. And I think also when you see a patient with like some kind of exposure factors, like if they have an open wound or if they have been bitten by mosquitoes or any kind of insect bites, that's where the botflies would hatch, basically deposit their eggs onto open wounds, or they deposit on the ground and the patient walks in bare feet, then they could get it, or they would attach the eggs to mosquitoes, and then through bug bites that patients get the larvae in, and then the larvae will hatch. And I think one other thing that I looked into is that even though botflies are like a parasitic infection, which you would kind of expect like eosinophilia, but in this patient, he actually didn't have an eosinophilia. His neutrophil, it was like predominantly neutrophils in his red blood cell count. And so I actually found that like because the larvae mostly stay in the subcutaneous tissue, so that's why we don't see eosinophilia. But if it penetrated beyond it, then we would see eosinophilia. So that's kind of like the major takeaways and the teaching point that I got out of this case. And I think as like a cognitive exercise for everyone, I was curious if anyone wanted to drop in the chat of the common endemic parasitic infection that came into mind in the Central America area, especially our friends who are from that area. Anyone? Yes, Yasmin here. I'm calling him Yasmin.
Promise, I gotta tell you, I often try to add something from personal experience or other clinical reasoning cases I've read or whatnot, but I was completely stumped. I had no idea what this patient had, and I had told myself that I would read about it, but then I was like, wait, why would I read about it when I can learn about it from the people who are going to recap? So I actually haven't read about it. I don't know anything about it. And that was such a beautiful summary. And I want, selfishly for me, but also because I'm a believer in spaced learning, to recap the highlights that you said, which is that this is a process whereby larvae are deposited usually on bare feet by people stepping on them or by an open wound in certain endemic areas. And cellulitis is the most often misdiagnosis, and the diagnosis is suspected basically upon exposure. There's no peripheral clues and no eosinophilia, and the treatment is just to remove them. So in this case, you really lean heavily on the patient guiding us that way, which I think was really, really cool. Yeah, I promise. I think, do you want to re-summarize what the name of the diagnosis was?
So I think they were thinking of myiasis,
Oh.
but more likely the patient probably just developed an allergic reaction to the larvae because like the arthralgia like didn't really fit the picture. Like he had other symptoms too, and like the rash. So it's Garlene said like they kind of think that is probably more of an allergic reaction, and then imaging, like they took out the larvae and he was better. So yeah, because with myiasis is mostly just like a lesion. I read and I didn't see any kind of like diffuse rash development like arthralgia. Like I don't see any of that. So it seems like it pretty much just stays on the subcutaneous tissue, and it's just painful like swelling and then erythematous and maybe itchy. Those are the main things you would see.
So cool. Absolutely fascinating. It's the first time that I think this has been featured on VMR. Really, really cool. Thank you for that recap. Really appreciate it. All right, on to Thursday we go. Ariel, take it away.
Hi, so Thursday's case was such a wild one. Shema presented to Yasmin and Robbie, took me on a wild ride. So to briefly recap, it was an older gentleman with 1 month of fever and bilateral ankle swelling for 7 days. But as the case progresses, we found out that the patient was also dyspneic and hypoxemic from lung infiltrates. He also has jaundice from liver involvement. He had splenomegaly, and we learned that he was from India and had recent exposure to flood. So at that point, I was like, what was going on? We had some lab work where we found out that he had a pretty profound neutrophilia with toxic changes, and that's what like anchored the case. So my first teaching point was just to recap what Robbie said. It was so eloquently put. So splenomegaly and hepatomegaly cue us into a granulomatous infection, but those infections are usually subacute and don't cause prominent neutrophilia and toxic changes like what we see in this case. And the only exceptions are melioidosis, which this patient was ultimately diagnosed of, Salmonella typhi, Yersinia pestis, TB sepsis, and tularemia. And Robbie taught us that when we see those granulomatous infections with prominent neutrophilia, we think about exogenous gram-negative ROS, which all these cases fall into. And I just really like that teaching point. So my second part, so Ravi said in the chat, like we can do like a schema of bugs in flood. I found that could be interesting. So I did like a little list, but because I'm not a medical student, like it's like really incomplete. I think what's gonna be more fun is to ask the group, because I was having such a big difficulty thinking through this case real time when we have so many organ like involvement and like so many manifestations. Where do we find our anchor point? It's kind of recapping what Madellena asked.
I think Ariel, just what people are thinking, I think this is a great case to actually illustrate some nuance on the topic that Madellena raised, which is, in this case, you almost have to lump different things and make them a point, right? Like, I think your teaching point summarized it so well, which is you said granulomatous plus neutrophilia equals these infections. And neutrophilia is a point, But all the other things is not a point. It's a point that you created and made in your own mind to say, hey, this looks granuloma like. And so I think sometimes dropping your anchor, it almost certainly comes with deliberate practice and experience. But in this case, I think you drop your anchor at a confusion. Like you're like saying, oh, wait, there's neutrophilia, but the patient's been sick for a month. That's weird. So what causes neutrophilia for a month? So in this case, I think you're not really connecting things. You're just pointing out the disconnect in a case. And that can be pretty powerful. You know, when somebody comes in and has dyspnea, hypoxemia, tachycardia, and clear lungs, you almost say, wait, hold on. They're dyspneic, they're tachycardic, but their lungs are clear. And so that disconnect pushes you to consider pulmonary embolism. And so we can talk about this topic forever, but sometimes your anchor point is dropped at the tension in the case, and that can unlock it. And neutrophilia and hepatosplenomegaly is a big tension. It's like tachycardia with clear lungs. It's a very, very odd combination with a very specific DDX. Yeah. Honestly, we could do a whole day of VMR for this topic. It's endless. Thank you for that great recap. And I just caught the chat right now pointing out the fact that you're essentially getting your you're paying for your veterinary training, but you're getting medical training for free.
Yes, that's the deal.
Oh my gosh, you really are one of us. Thank you, Daniela, for saying that. You really are. All right, last but not least, Rafa, Friday.
Wow, he didn't skip me this time. Okay, so
no, because you made yourself last. You know,
exactly.
Like literally, the only way I wouldn't skip you is if you're literally last.
It's strategy, my friend, strategy.
Yes, stress.
So this is yesterday's case was a 65-year-old female. She had a past medical history of mitral valve prolapse. It presented with low-grade fever, chills, night sweats for 1 month, associated with arthralgia and headache. Her labs were remarkable for leukocytosis, elevated GSR, elevated creatinine, microscopic hematuria, and positive rheumatoid factor. Talking about this journey of this patient, initially they suspect this patient have giant cell arteritis, and she was treated with low dose prednisone, but there was no improvement. And finally, they did a TEE that showed vegetations, and this patient was finally diagnosed with infective endocarditis. So I guess my first teaching point would be that sometimes treatment can be used as a diagnosis clue. So this patient was treated with low dose prednisone. And giant cell arteritis was the final diagnosis. We expected that with the low dose prednisone, this patient was much better in a few days, just like with polymyalgia rheumatica, for example. And it was not the case. So here we treated this patient thinking it was giant cell arteritis, but she didn't improve with low dose prednisone. So that goes to show that treatment can be a diagnostic clue when it comes to clinical reasoning. What do you say, Ravi?
Oh, I think that's the key pearl. Is you don't have no way of solving this case, but when patients get worse on prednisone, you have to figure out, did you give them enough or did you give them more? And I'm curious, I saw you were there in real time. How surprised were you that the patient had endocarditis?
Endocarditis is, for me, is one of those things that can have so many types of manifestations. I don't know if you remember, but for example, Gerling brought us onto a case that no one suspected of infective endocarditis. It was just low back pain, you know. And I was reading that, like just 5%, the range of presentation is so large, you know, and it's one of those things like when you're dealing with a clinical no, always put infective endocarditis on your differential, just like TB. You never know how it's coming for you.
100%. I couldn't agree more with you. I think there was an RLR case where the patient had a prosthetic aortic valve, so at risk of endocarditis, but he's 89. He's had that valve in his heart for 10 years. He came in with 3 weeks of fatigue, no dyspnea, no exercise intolerance, no weight loss, no lesions, normal labs, culture's positive, 2 out of 2 for coag negative staph. So I don't know. I give up. It makes me give up.
But let me tell you my second teaching point. Maybe this can help you.
Okay, thank you.
So this patient had fever and chills, and every time we listen to chills, automatically we think about bacteremia, right? And this is something that Reza discussed about, like what do we need to have infective endocarditis? A transient bacteremia and a vulnerable valve. This patient had mitral valve prolapse, but no one paid attention to that. And then she actually had a transient bacteremia due to the chills. So actually the diagnosis was in the history alone, if you think about it.
Yeah, no, I think in that situation for sure, the fevers and chills are very, very powerful, and the fact that there's a vulnerability, very, very humbling diagnosis. But the fact that she got better too was it was surprising to me. Most people who have endocarditis for that long don't recover fully. Yeah, we'll just open up to questions from the group before we recap.
Oh, someone mentioned on the chat, like this patient had a T negative in the beginning, and we were talking about that, like the case presenter was telling us that it's a parent dependent. So maybe perhaps the operator didn't have enough knowledge when it comes to vegetations, the first operator. And I was reading also about it. The sensitivity is actually 80–85%, but the specificity is very high. So it's easy. It's not easy, but you can miss sometimes.
I actually had a question, Rafa, about what you just said. Rafa, I really liked how you kind of said the things that we should be thinking about to suspect endocarditis, like a damaged valve, so mitral valve prolapse, and then transient bacteremia. And then you mentioned, I think correctly so, that the chills in this case should have made us consider bacteremia. And I'm just curious, like how maybe specific chills is, like how much can we use that as a clue for transient bacteremia? I don't know that.
Oh, excellent question. I don't know either, but I've seen it Twitter many times. I think it was with Uncle Bob. He posted that paper, if I'm not mistaken. The sensitivity is very high. But could you please clarify, Robbie? I don't know if you.
No, you're on the right track. No, absolutely, you're on the right track. There's something here, but it's important to understand what you want to observe to call it concern for bacteremia. So a lot of people have chills, which is the feeling that they're cold, and all of you have had it at some point if you've had influenza, COVID, URI, where you just want to get under the blanket because you're really cold. Those are termed chills. Rigors are when you uncontrollably shake, like when you're literally like, oh my God, I'm so cold, as if you're shivering. So if your patient is shivering spontaneously without it being cold, that's rigors, and that's very predictive of bacteremia. Chills is not so much. So most people report chills, but rigors is unmistakable. It really, like, you'll literally see like the sheets shaking from behind. So why is this a source of confusion for many? It's a source of confusion because we're loose in our terminology. What's a good example? I can't think of a good example spontaneously. So a lot of people will say, oh, the patient had rigors, but they meant that they actually had chills, so that they weren't actually overtly shaking. Yeah, does that make sense? Rigor is very, very predictive. Chills, not so much. Chills are predictive of an infection, but not bacteremia.
One question: was your Twitter today about this case?
Yes, 100%.
Yeah, because you're talking about microscopic hematuria and elevated creatinine.
Yes.
Infective endocarditis was not on the list when I read the Twitter, but maybe someone will post that.
Yeah, no, gosh, maybe we'll save that for next time. I want to make sure that the spotlight remains on your terrific teaching points. If we talk about that, it'll be at least another 10 minutes. Yeah, but that isn't, if you're on Twitter, you should reflect on that dimension. That was another interesting dimension of the case, but Rafa has brought us two great ones, so we'll keep it at that. And I think it's incredible to think about what VMR brought this week. And we started off with hanging out in the esophagus and learning from Shima the importance between odynophagia and dysphagia. And she taught us so well the list of infections that cause infectious esophagitis, and reminded us to be humble and not to exclude infections in immunocompetent patients, with HSV being a notorious cause of infections in immunocompetent patients. And Madellena, I think, opened up a really interesting conversation about how we solve problems. And I think how we solve problems is a function of what we think the problem is. And sometimes that's really, really tough. But I will share with you that sodium is usually not the core problem. Usually it's a manifestation of the severity of the problem. And there's only one exception. It's when the patient has pretty severe ADH, usually SIADH. And that begets the hypotheses that your patient has small cell carcinoma, that gets the hypotheses that your patient has adrenal insufficiency or acute intermittent porphyria. And all the fancy smancy diagnoses that live in hyponatremia all live in the world of SIADH, which means that the urine osms are usually really high. So don't invest too much time in the sodium if the urine osms aren't super high. And Debora taught us the magic of point of care ultrasound, and also made the important connection between seeing a pleural effusion and IVC distension. And always remember that any cause of high pressure in the thorax, from pleural effusion, from pneumothorax, from pericardial effusion, can also just compress, just like a pericardial effusion. And then promise, I don't even know how to recap your case. It was like, I'm at a beginner level. So I will just say, gosh, thanks for the patient and them recognizing their local epidemiology. And thanks to you for summarizing it so well and teaching us that eosinophilia may not be a feature of this very superficial subcutaneous infectious process. And then Ariel, again, opening up that conversation about the pivot point in a complicated case of melioidosis. And I think in that case, it was a great reminder to sort of like finish off Madellena's conversation about how do you find the problem. Sometimes the problem is that things don't add up, and you look at what doesn't add up as a powerful clue. And that was it. That was the entire end of the week. We didn't have any other cases. I'm kidding, Rafa. I won't skip you again. I don't even know how to recap Friday. I was humbled in the moment. And I'll just say that if somebody is not doing well for some period of time, so a subacute failure to thrive, make sure you think about endocarditis. Even like if you don't have anything else, but the patient has subacute blank, you should think about it. I think that's a great sensitive way to approach it. All right, y'all, I'm going to end the recording. Thank you all for hanging out. And